Well, thank you for having me, and welcome to all the rookies here. My first presentation, I made to this particular group was actually in 2011. So I don't know that anybody was here in 2011. So in a way, I'm glad because I've cheated a little bit and I used some of the same slides. I've updated some of them, but some of them are the same. And my name is Mihnea Dumitrescu, which is a Romanian name. Very good guess. I apologize for the name. I had absolutely nothing to do with it. My parents, I guess my parents never figured out I'd be living in Texas for the rest of my life, but so goes it. There's a website there, which is the website of my practice. I was not very well prepared and I didn't bring business cards. But Nancy and I go way back, and if anybody has any questions and would like to get in touch with me, just ask Nancy. She has all my my information. My practice is down the road here in Westlake Hills by the Hills Fitness Center, and I'd be more than happy to answer any questions that you may have on a personal basis. We're going to try to talk a little bit about neuropathic pain, about the options of management of neuropathic pain. I've looked a little bit through the website that you have in the other presentations, and I don't know that I'm going to add amazing insights to what you already had. I don't know that all of you have seen all the presentations. It's pretty comprehensive, actually, what you have on the website. So I'll try to go through the technical parts pretty fast. I don't know that we're here to learn about neurotransmitters for pain and stick to the main points and some hopefully some take-home message here. So I'm sure that all of us in this room have had pain at some point or another. So I figured I'd start with the definition of pain, right? Pain is defined internationally as an unpleasant sensory or emotional experience, right? So right at the outset, I'd like to point out that pain doesn't necessarily mean physical pain. It could also be an unpleasant emotional experience. I'm going to touch on this later on in this presentation because the management of pain is not just managing the physical aspects of pain, but also the emotional aspects of pain. So this unpleasant sensory emotional experience is associated with actual tissue damage or described in terms of this damage. So what this means is you don't actually have to have damage to your body to have pain, right? So this is also important because a lot of what's done in pain management these days has to do with the physical aspects of pain, and not a lot has to do with the emotional and psychological aspects of pain. So the definition states that they're both very important. Now, this is a busy slide. I just want to point your attention to the first three parts, A, B, and C. A and B, the nociceptive pain or inflammatory or joint-related pain is pain related to a damage to the tissue, right? So the tissue is damaged, we have a nerve that goes to the brain, and then we feel pain. Neuropathic pain, right? Neuropathic pain is actually the result of a nerve damage, right? So it's not the joint, it's not a pain from the knee joint that becomes arthritic, or somebody punched us in the face, and our teeth hurt or something like that. The neuropathic pain is different. Neuropathic pain relates to nerve damage, and it's usually peripheral nerve damage in the hands and feet, something in the periphery of the body. So the classification is important because obviously the management of the pain is important. I left this slide in. I took a lot of slides out because there were a lot of minutiae that I'm sure that nobody really cares about. But I left this slide in because, again, I wanted to point out the parts of the brain where we perceive pain. And you can see that the red part is the only one where we perceive just pain. All the yellow parts is where we perceive pain and emotion at the same time. So treating pain, treating the body without treating the emotional or psychological aspects is probably going to be futile in the management of pain. There are a lot of parts of the brain where pain and emotion are perceived in the same areas. So is pain a problem? Of course it's a problem. You can see, this is a slide from 2011, but you can see that pain, about 26% of the population has pain at any given time, and compare that to diabetes, coronary artery disease, stroke, and cancer. So it's obviously an important issue. As far as how long pain lasts, the red part of the pie charts is the duration of chronic pain, and you can see how we advance in age. As we advance in age, we have more and more chronic pain. 65 years or older, pain duration is 1 year or more. So this is also important because going around the room, obviously, most of you have pain. Most of you have probably had pain for longer than a year. And it's important to know that. Now, what I'd like to do briefly is talk about what people believe chronic pain is and what it actually is, or what people believe chronic pain should be treated with, and really the standard treatments there. So you've probably heard a lot about this, that there's no standard of care to treat chronic pain. Everybody gets addicted to drugs. I mean, if you watch the news, you'd believe that everybody who actually takes one pill is instantly addicted to medication. And I've had patients who are absolutely terrified of pain medication. There's a common myth that you just have to live with your pain, and also the common myth that all pain patients have psychological issues that precede the pain, right? Well, I'm going to talk a little bit in what follows about each one of these, and hopefully by the end of it, you'll have a better idea of the truth here. So chronic pain, it seems that, well, maybe not everybody, and I'm sorry, Doug, I'm going to have to un-Google you now. I spend a lot of time un-Googling my patients. So chronic pain. So chronic pain, what is chronic pain? Well, if pain has lasted for longer than 6 months, and it has psychological, emotional features, and it limits the person's ability to function, then you have chronic pain, right? Now, this is a very flexible definition, right? So if you've had pain for 4 months, do you have chronic pain and you have all the other features? Yeah, absolutely, right? So, we have to have some delineations. We have to have some numbers. We took 6 months as a number, but again, that's flexible. The types of chronic pain, just like we talked about in that busy slide, you have nociceptive pain, which is basically damage to the tissue itself. I have loss of cartilage in my knee, or I've torn my ACL in my knee and I have pain in my knee. That's nociceptive pain. You have neuropathic pain, we touched upon, which is damage to the nerves, and then mixed. You can have both nociceptive and neuropathic pain at the same time. So again, neuropathic pain, which is the main interest of this group, it's a result of an injury to either the peripheral nervous system or the central nervous system. And most people don't think of everybody knows CIDP, everybody knows a peripheral neuropathy, diabetic peripheral neuropathy. Those are big problems, but there are other examples of chronic pain that are still chronic pain. For instance, sciatica, right? Sciatica is actually damage to a nerve root in the lumbar spine. Shooting pain down the arm, damage to the nerve root in the cervical spine. CRPS or RSD, reflex sympathetic dystrophy, you've just had an injury, you've just had surgery, you damage the nerve, and then you have this pain that is completely out of proportion to everything you've ever had before or to the stimulus, right? That's chronic pain. Carpal tunnel syndrome is a chronic pain issue. It's a damage to a particular nerve, the median nerve in the wrist, right? Herpetic, post-herpetic, shingles, right? Shingles is neuropathic pain. It's caused initially by a virus, but it's still damage to a nerve. Finally, phantom limb pain after amputations. That's chronic pain, although clearly it's not due to damage of a particular nerve, right? So that's more of a central nervous system problem rather than a peripheral nerve problem. So neuropathic pain is a big, huge category, and obviously we don't have time to talk about every and each one of them. So we're just going to talk about just more sort of general concepts here. So when you go to the doctor and they measure your pain, it's usually that you're being asked, well, what's on a scale of 0 to 10, what is your pain now, right? I mean, that's called a numeric scale, right? Because it gives you 10 numbers and it tells you to pick one. Now, the numeric scales have been used for a long time and they have their merit, but really pain should be measured not only in terms of numbers, and if we use numbers, we should use one of these analog scales where they just give you a line, right? And you put an X on a line without numbers. They've been validated to work better. But pain should also be measured through psychological testing and measurement of function, right? Because how it impacts your psychological status and how it impacts your function is just as important as that number that you give the doctor. So if you go to a physician and they don't ever ask you, well, what does this condition prevent you from doing, right? That's probably just as important for most people than I have 5 out of 10 pain or 6 out of 10 pain, right? So it's the measurements of pain. In pain management, we try to do this, although not every pain management practice or physician does this. It's important for you to know that not to focus on just one number. So why is it important to manage your pain effectively? Well, the first thing here is when you first start having pain, there are changes that are happening in your body, right? There are changes that are happening in your peripheral nervous system, and then you have all these wiring going up to the brain, and there are all these changes happening in the spine and in the brain. As these painful stimuli, as these painful impulses affect your body for weeks and then months, these changes in the spine and in the brain become entrenched. You undergo a process of rewiring, right? We called chronic pain patients rewired patients because at some point you don't really need to have an outside stimulus causing pain. You have a feedback loop where your nervous system actually keeps you in a painful state, right? So I'm telling you this because if you start having pain, and for most of you it's probably at this point it's just probably not too late, but maybe you have friends or family that goes through this. When you first start having pain, it's important to see somebody, and it's important to see somebody who knows what they're talking about, so you can, if possible, reverse the acute pain, catch the pain in its acute stage, don't let it get to a chronic phase, right? So if you can get it under control within a week, these changes happen very fast too. It's a matter of weeks, right? So if you can get your pain under control within a week or so and start rehabilitation, that's really very important. And why is it important? Because poorly managed pain can lead to all these conditions that I've listed there, and also psychological deterioration. So this is something that it's obviously best avoided, right? It's also very important to understand that it's not just the doctor, right? It's not just the doctor. Most of us go to the doctor, or maybe most of us go to, a physical therapist or something. It's, effective chronic pain management is a team-based approach. Now, this is difficult because in healthcare in the United States these days, the team-based approach are not encouraged, right? There are certain clinics, and you hear about them, Cleveland Clinic and Mayo Clinic and all this, where they emphasize this team-based approach and they have great results. But for most of us, you go to your primary care physician, maybe you go to a neurologist, maybe you go to a pain management doctor, maybe you go to a physical therapist. Nobody talks to anybody else. Nobody has access to anybody else's notes. We spend an inordinate amount of time in my office trying to get notes from other practitioners that are involved in our patients' care. So it's always very hard to do this. So,
Why is that?
Well, there's several reasons. Number one, we do not have electronic medical record systems that talk to each other, right? We have a bunch of disparate, electronic systems. Everybody has their own, but none of them. We don't have a centralized database for every patient, and that's for whatever reason, right? It's a big country. We have 50 states. People are distrustful that somebody will manage all their data. Whatever the reasons, Peter. Whatever the reasons for that, but that's probably the main reason. The second reason is the doctors don't have time to do it, right? I mean, so as a physician seeing a patient, you don't get paid to collect data from other physicians, right? So it's up to your office and it's up to other physicians' offices to do that, and unfortunately that's not getting done very well, right? It's just a simple lack of time and lack of incentives to do that. So it is up to you, right, really? The reason I'm telling you this, that it is up to you to keep everybody involved in your care on the same page. And if that requires getting your notes from all your practitioners and having a folder with all your notes that you take to everybody else, it's really just individual responsibility. If you want to have good care, you have to be involved in your care, because I don't think that your doctor's offices will do it for you, right? So all these teamwork, all these members of the team that I listed here on the slide are equally important, right? So physical therapists, psychologists, pain management, etc. The other big problem with this slide is that the third one there on the list, psychologists and psychiatrists, right? It just doesn't exist, right? In Austin, Texas, there are almost no psychologists or psychiatrists that specialize in chronic pain, right? None. Texas is 49th out of 50 states in how much we spend on mental health, right? So there are just no resources out there. I mean, I have chronic pain patients that I treat that I would love to send to a psychologist or a psychiatrist, and I can't, because most of them either don't take insurance or they're just none, right? It's not a, very, seductive field, so to speak, in psychiatry. So there are some barriers to this, but teamwork is usually what gets the job done. And this is another slide that illustrates the same point, right? This is the pain management is a continuum, right? It starts with drugs, and there are all sorts of therapies and all sorts of people involved in it. So I'm going to touch upon each one of these little boxes just to give you a little bit of an idea. I don't want to get into too many details, but I just want you to be aware of what's out there, right? So the first box is obviously some anti-inflammatory medication, over-the-counter drugs. We all know these. I'm not going to spend too much time on these. We probably all have taken these at one point or another. The second box here, you see the physical therapy and the modalities, right? Physical therapy is important. There's no question about it. People go to physical therapy, go to chiropractors, exercise, obviously very important, decompression, massage, all these modalities, nerve stimulation and things like that through the skin, ultrasound, desensitization. Those are all very important in the management of pain. Third box here, complementary medicine, behavioral programs. So complementary medicine is something that I think you've had some talks on. I looked at the website and I think you've had some people talk about this. I just want to mention it here. There's acupuncture. A lot of people use acupuncture, aromatherapy, any of these, like you were saying, Chinese or Asian systems or any other systems of therapy. I don't think that any of us have the answer, right? Just because I do neurostimulation or nerve blocks or whatever doesn't mean that my methods are the best, right? If people find relief in acupuncture, I say more power to them, right? So consider complementary medicine. Do not be afraid. They've been around forever, right? They've been around a lot longer than Western medicine, and they're still around. So hopefully they're making some people better, right? Behavioral programs, we touched upon psychological counseling and the lack thereof, and then relaxation techniques. You mentioned Tai Chi. It's over there, yoga, biofeedback. This cognitive behavioral therapy is called the poor man's psychoanalysis, right? Because it's a short program. It's usually 6 to 12 weeks, and it's intense. And basically what it does, it teaches chronic pain patients to think about their problem in a different way, right? So it teaches you to compartmentalize this problem in a different way, right? So it is proven, to work in chronic pain of all sorts, including neuropathic pain. Unfortunately, not very widely available. Again, more medications, right? So we talked a little bit about the steroidal and non-steroidal anti-inflammatories in that first slide. There are a bunch of other medications here. I'm not going to go through all of them, just very quickly. Antidepressants are used. Some of you may have been on Cymbalta or are on Cymbalta or Savella. You have the neuropathic pain specific to the nerves. These are anticonvulsants like Neurontin or gabapentin, Lyrica. People use Tegretol, carbamazepine, and Requip for different other neuropathic pain issues. Yes, sir?
Have you ever had any patients have problems with Lyrica?
Oh, patients have problems with all medications all the time. Lyrica in particular, I think, is a wonderful drug, but obviously it has side effects, right? The most common side effects that I see with Lyrica are actually memory loss. People complain of being foggy, right? Some people, although fewer, have some weight gain, in the extremities, but usually people stop taking Lyrica when they can't find their words anymore, they have memory issues, they have this mental fog, in which case they can't go on. But it is really of all the medications that I'm going to talk about, I think Lyrica is really a wonderful drug for neuropathy. Now, it doesn't work in everybody, obviously, but...
What have you found to be the effective length of time and the point where in most it becomes a problem?
I've had Lyrica, I've had patients on Lyrica for years, right? Most people, if they're going to have these problems that are going to force them to discontinue the medication, is usually within the first 6 months or so, right?
It happened to me, and it was after 5 years.
Yeah, well, there's always the outlier, right? Most people, I would say, within the first 6 months will have these problems. The idea with Neurontin and Lyrica is to start at a very low dose, right? And build up slowly, right? Because a low dose may be effective. Some people just take too much, right? Sometimes when you have these issues, if you lower the dose, you may still get the pain relief, but not the side effects, right? Buclofen is a muscle relaxer that acts on the GABA neurotransmitter. It's also used for neuropathic pain or chronic pain in general. There are all these topical medications. Maybe you've been exposed to them, lidoderm patches. Since neuropathic pain sometimes it's a problem of peripheral nerves, right? So application of anesthetics and other topical drugs on the affected side, site of the body, sometimes is effective, right? So they make all these compounded creams now with everything in them, right? It's a big industry. You may have trouble getting your insurance to cover them. They are pretty expensive if you pay out of pocket for them, but if they are effective, they might be worth it, right? The ones that are sort of under the insurance realm are the lidoderm patches and Flector patches, Voltaren gels. These are usually covered by most insurance. The topical compounded creams, not so much. And just like everything else, it's turned into a big business, and it's been taken out of control because of profit. But you know, it may still be worth it if it really, really works. Now, we've talked about some types of neuropathic pain. I know that nobody here is probably suffering from this, but you know, things like sciatica, right? Things like complex regional pain syndrome. Sometimes what we do in pain management, which are these interventional procedures, right? These are usually nerve blocks, or you've heard of epidural injections probably. I mean, people call them cortisone injections. You know, we do a lot of these, you know, on a daily basis for different types of pain, including neuropathic pain. Maybe not peripheral neuropathy or CIDP or things like that, but certainly these are part of the continuum of you know, pain, chronic pain, or neuropathic chronic pain management. And I'm not going to bore you with all the details, but they are there, and we do them. So we are now sort of right about here. You know, we're getting into the corrective surgery part, right? Now, surgery. Surgery begets surgery, right? So now surgery is effective if done for the appropriate diagnosis. Now, people with peripheral neuropathy, people with demyelinating conditions, you know, they're not going to be responding to surgery. But if you have sciatica, if you have a nerve irritation or inflammation caused by a disc hernia, sometimes having a surgery is important. If you have nerve damage or nerve impingement because you have scoliosis, sometimes straightening your spine is important, right? So surgery has its place, maybe not a prominent place in the neuropathic pain continuum, but it has its place. Moving to your right side, long-term oral opioids. Well, here's a problem, right? Opioids. I don't know how many of you have tried opioids or are on opioids right now. You know, if you watch the news or you listen to the news, you know that this is a problem, right? We'll talk a little bit about the problem. First, I want to just tell you, just in the most general of terms, about opioids. So opioids are basically derivatives of morphine, right? Opium comes from poppy seeds. It's synthesized into morphine, and morphine is a very potent, maybe the best, you know, drug for pain out there. You know, it's been used for thousands of years. The humanity has been fighting for opium for thousands of years. You know, opium wars. We're still probably fighting wars for opium right now. They're clearly effective. They're basically divided into two categories: the short-acting opioids and the long-acting opioids, right? So the short-acting opioids are the ones that you take. I have some pain, I'm going to take something. It kicks in pretty fast. It lasts 2, 3, 4 hours, and then it goes away, right? They're used very frequently as a reaction or a reactive treatment to pain, right? I've just hurt my knee. I'm going to take some hydrocodone. You know, my knee hurts. Then my knee's not going to hurt. Now, if you have chronic pain, if you're hurting all the time, short-acting opioids are probably not the best, right? Why? Because they reinforce a pattern, right? Every time you reinforce a pattern, you can generate addiction, right? You can generate, if your pain is like this, right? It's a sinusoidal pattern like this. That reinforces a behavior, a treatment behavior, and that's not good because that creates dependence, that creates tolerance and addiction. So we formulated now these opioids. I say we. The pharmaceutical company has these opioids now that are long-acting. And the idea of a long-acting opioid is that it kicks in slowly. It kicks in slowly, but it stays at kind of the same level for a long period of time. And this period of time can be anywhere from 8 to 24 hours. So these long-acting opioids are better for chronic pain because they don't give you the up and down pattern of pain, no pain, pain, no pain. Now, as with all opioids, the three main problems are dependence, right? Now, dependence is not anybody's fault, okay? Dependence is something that happens to almost all of us who have taken opioids for a long period of time. It's basically feeding your morphine receptors in your body a steady dose of morphine, and they get used to it. So if you take away the opioid from these receptors, they're going to start screaming, right? like those hungry, birds, right? They're going to start screaming for more, and this is going to create a withdrawal response. Now, a withdrawal response, everybody's absolutely terrified of withdrawals, right? A withdrawal response is a very unpleasant experience. It's like having the flu, maybe times 5 or 10, but it is a short response, limited response. It may be 2 days, maybe 3 days, until the opioid dependence or the opioid clears off your system and it goes away. So dependence is something everybody will experience that takes opioids for a long time. Tolerance is also something that everybody experiences. What does that mean? That means that you have to take more and more medication to achieve the same side effect. I mean, the same effect, not side effect, the same effect. So I start out by taking 1 pill a day, and then I have to go to 2 pills a day, 3 pills a day, 10 pills a day. So tolerance is bad because as we increase the dose of opioids, the side effects will also increase, right? So we become tolerant, you take more and more medication, and then the side effects are just going to be too much. You're not going to be able to take anymore. Addiction is a problem, but it's a small problem, actually. It's probably ranges estimate from 5 to 15% of people who are on long-term opioids get addicted to them. And addiction means that if I tell you that the drug is harmful and will kill you, you keep taking it, right? That's when you know you're addicted. And addiction usually goes hand in hand with some sort of an illegal type of a behavior. Either you get your drug from more than one doctor, or you buy it off the street, or something like that. So addiction, I don't want to minimize addiction. I mean, obviously it's a big problem, but it's really just a very small portion of the patients who take opioids that get addicted, right? Yes, sir.
Would you address, or are you going to address marijuana?
No, not necessarily, but we can address it right now. Just get it out of the way. I am 100% in favor of using cannabis as a pain management technique. Now, I don't agree with smoking it for obvious reasons, because you don't want to get lung cancer from smoking something, but now, medical marijuana is legal in 20 states now, right? Not here, obviously. I have now patients, as you know, everybody moves to Austin these days, right? So I've had patients from California, from Oregon, from Washington, D.C., I mean, you name it, Colorado, all these states who come to me and say, well, I've been using marijuana to treat my pain, right? And, I have this conversation with all of them. I said, look, in Texas, as of now, hopefully you guys are going to vote, right? But as of now, it's illegal. I cannot really prescribe marijuana. And if you use marijuana for pain management, I cannot prescribe these other medications, because obviously, I can't feed you a bunch of pain medication that can interact with each other. We don't really know what it does. But I have read several studies now, since it's been legal and it's been used more, that it actually is effective, right? Not only that, but very interestingly, right, in the states that use medical marijuana, right, the Medicare expenditure for pain management has decreased by tens of billions of dollars, right? So it's not only effective, but it makes sense from a money standpoint, right? We all talk about how expensive our healthcare system is, right? So if you look, they did 2 or 3 states, I don't remember exactly off the top of my head which ones, but they saved year on year billions, tens of billions of dollars in drug costs, right? In Arizona, I have a friend who practices in Arizona, in Phoenix, and the biggest contribution to the anti-legalization campaign of pot in Arizona is from the drug companies. The drug companies actually contribute the most to the anti-pot campaign in Arizona. So that should tell you something, right? So this is, my feel is that if you use it in a non-inhalable form, or an inhalable form that doesn't kill your lungs, right? And it works for you, I would say go for it. It's probably not as harmful to you as some of the stuff that I write prescriptions for every day.
But do you think it's, in most cases, very beneficial for neuropathic?
I think it could be, but it's a trial and error. As you know, I mean, I have neuropathic pain patients who use it and love it, right? I have people who have tried it who say it doesn't work for me. The problem is, unless now we have the genome decoded, so hopefully if we have this conversation another, well, it's been since 2011, so another 5 years from now I come back and talk to you, right? Hopefully I'm going to have a talk that says, you know what, it costs $500 for me to decode your genome, and I'm just going to check all these genes, and for you personally, you know, I think this particular drug will work, right? Until we get there, though, it's a trial and error situation, and all I can say is you have to try it, you know, because now it's illegal, so.
I've tried many different things, even spinal stimulator with you. But I have a very dear friend who came back from Colorado and brought me 3 patches. I would never smoke it, but she brought these 3 patches because she knows my condition.
Yeah.
Fortunately, I did not try it until I called my doctor at Austin Pain Associates,
Yeah.
and they said, if you take that, it will show up in your urine sample, and we can no longer treat you or prescribe the narcotics that you're now taking.
They can treat you, they cannot prescribe the narcotics, right? I mean,
You know, the only thing that I have found. So
right. I mean, it's you know, nobody wants to lose their license, obviously. Nobody wants to encourage illegal behavior. But I mean, if you look at the data, really, it seems like it has a place maybe on that continuum. We should put, you know, marijuana there, you know, or under, you know, medications, we should put it there. I think that as long as it's don't consume it in a harmful way, I have absolutely nothing against it.
You're not growing it in your backyard at this time?
No, I don't, you know, it's shaded, so I don't think I have enough. Yeah, but
I know a good real estate agent could get you.
we can talk after this, right? Okay, so we are now sort of more in this area here. I'm not going to talk to you about intrathecal therapy. I don't know that that's used widely anymore. But neuroablation, well, neuroablation is when we actually cauterize or kill nerves. This is not necessarily used for neuropathic pain. It's mostly used for nociceptive pain, so pain from joints in the back or knees or hips and things like that. But it has, you know, sometimes people freeze these nerves. So let's say you have occipital neuralgia or things like that. These nerves can be the sensory nerves, so just the ones that cause pain or transmit pain, can be either burned or frozen for a particular time frame, right? These nerves regenerate, right? We were all told, you know, including me in school, that once you kill a nerve, it doesn't grow back, right? And when you have peripheral neuropathy, you think, well, nerves don't grow back. But these particular nerves that we ablate, they do grow back, they do regenerate, so the pain relief is usually temporary. Now, if they do grow back, you can do it again, obviously, but this neuroablation refers to destruction, right? Surgical or non-surgical heat destruction or ice destruction of a nerve. Now, you mentioned neurostimulation. You know, this is you know, again, a form of therapy that has gained a lot of traction over the years. Spinal cord stimulation has certain benefits, right? Clearly, if it works, the idea is that you're not going to take medication, or you take a lot less medication, which is great, right? It is reversible, right? If it doesn't work, you know, the systems can be taken out. It does give you a chance to test drive the car before you buy it, right? So it gives you a trial period when you first do it. You see how it works, you go home with it, you play with it, you turn it on, you turn it off. There's absolutely no pressure from anybody, and you can just make up your own mind, right? Surgery doesn't give you that, you know. A lot of things don't give you that. There are obviously small surgical risks that are actually very small. So this is a little slide that kind of illustrates what it is. Basically, it's got a little battery system. It's got 2 leads that get implanted and placed over the spinal cord, right? And there is a remote control type device that you turn this thing on and off, and you can vary the programs. It's obviously FDA approved. It's been around for, I guess, 40 years now, and it's usually used, as far as neuropathic pain, for intractable neuropathic pain. So you've tried everything else, nothing else works, why not try this, right? So the process is, the trial itself is an office procedure. It's sort of like an epidural injection. These 2 leads, plastic leads, are placed through hollow needles in the lower thoracic spine area. And what they do is send these impulses through the spine onto the brain. And if you have pain in these areas here, then you feel a tingling sensation in the same areas. The newest systems actually act at high frequency. So when you stimulate the spinal cord at high frequency, you don't even feel the tingling anymore. Basically, you feel no pain anymore if they work. The same can be done for the arms. The implant is put in the cervical spine or in the neck. So it's a pretty nifty way of treating pain. It does involve a little bit more aggressiveness in the way you treat it. The implant, though, should be, in most cases, an office procedure. It takes half an hour to an hour. You go home, and then you see how it works, right?
What's your success rate with it?
I would say that for neuropathic, no, I have to be careful here, right? People who have pain, nerve pain from the spine, right? So the nerves in the spine are being compressed, or they've been somehow damaged by surgery, or anything related to a spinal condition, and they have this shooting pains down the legs, right? Now, the success rate for that is in the 80%, right? A lot of people get better with that. And I'm including people who have back pain too, right? Now, if you have, say, peripheral neuropathy where you don't have nerves anymore, right? So there is destruction of the nerve, right? The success rate is about 50-50. The reason for that is because if there's no substrate there to transmit the pain anymore, it's really hard, right? It's really hard to capture that. Now, this high frequency stimulation, right, has been around now for maybe 6 months to a year, right? I haven't tried it as much as the old type, low frequency stimulation, and I'll get back to you in a year or two when I've done enough. We'll see how it works, because it's a different mechanisms. We don't really understand it very much, right? We just use a different frequency in the lab, and for some reason people get better results, right? So it's one of those empiric things that we do. But it seems people love it. You know, it requires a little bit of bigger battery because it works all the time at higher energy, right? But people seem to love it, and I can't give you a number because simply I just haven't done enough of them, right? So I would be wrong to give you a number. Anyway, well, this slide is not that important. The way it works really is, if you think of pain as a flow of electricity going from your hands or your feet going up into the spine and then to the brain, right? This puts a roadblock on that, right? So these 2 leads, they have these little tiny electrodes, right? And we send signals of energy through these electrodes that basically close the gates to all the pain signals that come from below, right? So it's just a roadblock. It's called the gate theory of pain. It was discovered by these two gentlemen, Melzack and Wall, in I think it was 60s, yeah. And basically what we do is we close those gates, right? It's a trick, basically, that we play on the brain. Clinical applications, obviously, as far as this crowd is concerned, traumatic injury to the nerves. It's used for CRPS, spinal cord injury, MS, peripheral neuropathy, things like that. It's got other, obviously, applications worldwide. believe it or not, the biggest application for spinal cord stimulation is chest pain from heart disease, right? So intractable chest pain is actually worldwide. It's not used, it's not FDA approved for chest pain in the United States anymore, but it's actually chest pain that's the biggest application for that. Well, so hopefully what I was trying to do with this is give you a little bit of information about types of pain, give you a little bit of information about how pain is measured, right? And what you should look for when you measure your pain, and in terms of the success of your treatment, not just numbers, but function and all that. Give you an idea of what can be done on a continuum of care, from physical therapy, exercise, all the way to implantable devices, right? And make you aware of the field of pain management and what we do in the field of pain management, and maybe some of the shortcomings, that we're faced with in terms of psychological, treatment for chronic pain.
Thank you. Thank you.
You're welcome.
Is your presentation available online?